Hi, my name is Wojtek Morzycki. I'm one of the medical oncologists from Halifax, Nova Scotia. I'm chair of the thoracic oncology group at Nova Scotia Cancer Center.
What is the standard treatment regimen given to patients with stage 3B/4 squamous cell carcinoma of the lung after progression on platinum doublet chemotherapy?
Well, at the present time, I think the guidelines are suggesting using docetaxel, which is probably the most favored of all drugs. This is a very difficult group of patients to treat. Squamous cell carcinoma is extremely resistant to chemotherapy, and I think docetaxel is probably favored by most of us.
In LUX-Lung A, the median overall survival was significantly higher for patients taking afatinib compared with erlotinib. Can you comment on this result?
Well, this is probably one of those interesting observations that we actually see second generation EGFR inhibitors being not just active in mutation positive first-line non-small cell lung cancer, but also in squamous cell carcinoma as well. So this is excellent result, giving us another tool to treat very resistant form of malignancy.
Will the overall survival data change how you treat patients with squamous cell carcinoma of the lung?
I think afatinib should be considered to be another choice for this group of patients, particularly with the excellent toxicity profile. As the fact that this is oral drug, and I think the fact that this trial shows the overall survival. I think we should consider afatinib.
Quality of life and lung cancer-related symptoms were found to be significantly improved in patients receiving afatinib compared to erlotinib. Cough, dyspnea, and time to deterioration for afatinib versus erlotinib was longer. Changes in pain were similar across groups. Changes in scores over time significantly favored afatinib versus erlotinib. Can you comment on these findings?
Yeah, absolutely. Every time we treat patients, we always consider the quality of life being an important aspect of every patient being treated. So seeing the afatinib having improvement in quality of life compared to erlotinib, that's again gives us more power to use this drug in the second-line treatment.
Overall, the adverse event profiles were comparable between the two drugs. 57% of patients in either group experienced grade 3 or higher adverse events. However, patients taking afatinib had a higher incidence of grade 3 diarrhea and grade 3 stomatitis, whereas patients taking erlotinib had a higher incidence of grade 3 rash. Based on these results, can you comment on whether patient quality of life is different between these two drugs?
I don't think it is. My experience with afatinib is actually the patients tolerating it quite well, and I can always reduce the dose from 40 to 30 milligrams, and the dose reduction is easy. Patients are tolerating lower dosages very well, with really no efficacy issue. So I'm not surprised that both drugs show some manageable side effects, and I think this should not be in any way obstacle for us to use afatinib in the second line treatment.
What is the take-home message from LUX-Lung A to physicians back in Canada?
I think the message is strong, and that is that the second generation TKI EGFR inhibitors, are, and in this case afatinib, is the very reliable, important choice in the treatment of patients with a very resistant form of the cancer, which is squamous cell carcinoma.
When you look at data from randomized clinical trials, what outcomes are important to you?
I think we are obviously having overall survival is the most important endpoint, but because of the frequently those trials are having a crossover design, the PFS I think should be accepted as an endpoint.
At ASCO 2015, a meta-analysis of 6 randomized clinical trials of gefitinib and erlotinib by Lee and colleagues demonstrated that despite significant PFS benefit, there was no OS difference with first-line gefitinib or erlotinib when compared with chemotherapy in advanced non-small cell lung cancer with common EGFR mutations. Can you comment on this?
Yeah, so again, those are two drugs. They're first generation of TKI inhibitors, and I'm not surprised about this, particularly with the mixture of sort of a different clinical trials. I think the fact that the combination, some mini meta-analysis of the LUX-Lung 3 and 6 has shown improvement in overall survival again indicates that second generation TKIs are superior to first generation.
What are the advantages of head-to-head trials?
From a statistical point of view, this is the only way to compare two perhaps similar drugs. And then we have, by doing the comparable head-to-head studies, we are able to define which one is better than the other.
Thank you. The CTONG 0901 head-to-head trial presented at World Lung in 2015 found that erlotinib was not significantly superior to gefitinib in advanced non-small cell lung cancer with either deletion 19 or L858R mutations in response, PFS, and OS, and had similar toxicities. What are your thoughts on this?
I'm not surprised about the result of this data. Those two drugs represent again first-generation TKI inhibitors, and their activity is very similar.
Earlier this year, Yang and colleagues published in Lancet Oncology an analysis of data from LUX-Lung 3 and 6 trials, which were conducted in patients with EGFR mutation-positive advanced lung non-small cell lung cancer. They showed that OS was significantly longer for deletion 19 patients taking afatinib versus those receiving chemotherapy. In LUX-Lung 3 and in LUX-Lung 6, patients taking afatinib in LUX-Lung 3 and 6 also had tolerable and manageable safety profile. Now the results of LUX-Lung 7, a randomized open-label phase 2b trial of afatinib versus gefitinib as first-line treatment for patients with EGFR mutation-positive non-small cell lung cancer, will be presented at ESMO Asia. Based on your experience and the previously published data, what do you expect the results to be?
I think we're all excited. We're very excited waiting for the result of LUX-Lung 7. I personally think this is going to be superiority trial, showing the improvement, advantage of the second generation TKI inhibitors versus first generation. I think the toxicity will be probably similar. That's my expectations.
Are you looking forward to seeing the results?
Yes, and I hope I will be there myself listening to the presentation.
The findings from the IMPRESS trial were presented at World Lung in 2015. Investigators found that patients who were T790 mutation positive, median PFS was shorter with gefitinib and chemotherapy compared to chemotherapy alone. In patients who were T790 mutation negative, PFS was longer with gefitinib and chemotherapy compared to chemotherapy alone. What are your thoughts on this data?
I'm not surprised listening to this data. Simply T790M mutation is a resistant mutation, and I didn't expect that the TKIs will be actually active in this group of patients. Chemotherapy is the better choice. However, in the patients who do not have this resistant mutation and purely EGFR mutation positive, TKIs are going to be superior to chemotherapy.